Good afternoon, everybody. My name is Hai Liang. I'm the moderator for this session today. Today we have with us Dr. Tee Ying Chew, a UMMC rheumatologist. Previously, she was my tutor, and she has been a very good tutor. And I have received similar feedback from a lot of other people as well. So, without further ado, let's welcome Dr. Tee lah.
Hi, morning everyone. Hopefully everyone is doing well at home and with all your online learning. I heard you guys going to come back to UM soon, right? In 13th of July.
Yeah, they are coming back.
Okay, sure. I think then we shall start with the first case first.
Okay, sure. So this is just a general overview. So before we start, I just have a few questions after doing some reading.
Sure.
Just as a warm-up lah.
Yep.
Okay, so these are my questions. So I've read Kumar and Clark. The first few pages, it said that most diagnoses of rheumatological diseases are clinical, then supported by investigations. Is that in any way true?
Yes, that's very true of that. Of course, I believe you all had read through all the disease in rheumatology like SLE, RA. You go through so many criteria for you to follow. So it looks very easy, right? Once you fulfill the criteria, then you will fit into the diagnosis. But for those had experience in the ward and see some real rheumato patients in the ward before, you will realize certain patients when after you see the case, you will feel weird why we say it's such a disease, but when you flip through your criteria, actually the patient is not really fulfill it, or you can see certain patient really fulfill, but eventually we say no, this is not SLE. Because certain diseases for you to the criteria is very easy to fulfill. A lot of patients will easily fulfill the criteria, but still you need to look at the overall picture, the clinical diagnosis. The lab is just to support you to support your diagnosis, to make it more convinced that this is such a disease. So we won't base on the lab result to diagnose someone with SLE. For example, patient go for health screening, they do a lab test outside, then they was referred to you with ANA of 1 in 800. So are you going to say the patient with SLE, if she without any symptoms, she is so healthy, just a routine blood screening? Definitely you are not. But they might have SLE, but SLE is a disease that sometimes it won't come even your serology is positive, you won't manifest all the symptoms and clinical features. Along a year, certain people will develop some symptoms, or some people can just have nothing happen as usual. So we always advise a lot of people not to do the unnecessary test when the patient is not indicated for, because you will cause a confusion and you will impose unnecessary stress to the particular patient, especially they turn out to be positive but they got no symptom. There's no significant treatment that you will give them either. Yep.
Okay, so I think that answers my first question. Second question is, okay, so for example, in patients that present with a lot of arthritis patients in rheumatoid, so what examinations are we supposed to do? Like, so I've read in Kumar and Clark, they recommend that we do GALS, which stands for gait, arm, leg, and spine. So clinically, do we actually do this examination, or we just examine whatever joints we have?
Okay, again, back to your history and your patient's presentation, which is more suggestive of which diseases. Okay, for example, single joint, which joint involved, what are the nature of the pain, is more mechanical, inflammatory. Of course, for in reality, ideally you should do the full things as suggested by your books lah. But then when for those been to our clinic, you will notice that we were very straight to a point. The answer is yes, you should do the full thing, but you will see when we practice in clinic, we didn't do as such because it's the times matter and the busy clinic. then most of our patients, especially those first presented, you are not too sure what is the diagnosis, you need to do the full to help you with your diagnosis. If someone you already non-RA, usually with no new complaint, we will just straight to the point to focus on the joint that actually involved. Yep.
Okay. So I think that should be all of my questions. So let's move on to the first case then. So I'll
Yep,
just read the
sure.
prompt. So Mrs. Chong, Miss Chong, an 80-year-old woman, presented to the rheumatology clinic with her daughter. She was referred to the clinic by an orthopedic surgeon and presented with multiple joint pain, including in the shoulder, hip, ankle, fingers, and wrist. So, doctor, my question to you is, so looking at this presentation, there are so many joints involved. Do you immediately go to a diagnosis, or is it just, oh, let's continue with the history first?
We need to further take the history. By the way, Hayden, can others see the slides? Because my slide is still stuck at the first page for my screen.
Oh.
Oh, it's just me or? Any feedback from others?
No.
I can still see the first page, case by case
Still
basis.
first page. Wait. How about now?
Yeah, can to rule out.
Now run to the fourth, fifth. I think your slides run, is it? Now
okay?
Now okay, yeah.
Okay, I don't know why, it must be my internet. Today I have a few less helpers, so I have to run all my things on my own laptop. So that's why a bit laggy. Okay, so yeah, so you were saying, doctor?
Yeah. Of course, every case they come to you, you need a very detailed history for you to come out with a diagnosis. But when the patient come to you with any symptom, a single symptom, first word they mention to you, you really need to have your differential in your mind, what are they? So that will help you to generate further question what you want to ask to help you to do in and rule out all your differential diagnosis. For example, these patients, what are the keywords in these three sentences? Multiple joint, which involves shoulder, hip, ankle, finger, and wrist, which is both your large and small joints as well. Okay, and the age of 80 years old. So what differential diagnosis will come to your mind with this kind of presentation? Of course, you want to think of rheumatic disease, you need further history to justify this is an inflammatory or this is mechanical. I believe those of you had attend one of the lecture on the approach to arthritis or something like that. That first you need to determine the site, which joint, and then the nature of the joint pain. Is it inflammatory or this is a mechanical type of pain? Then you can narrow down your differential diagnosis further.
Okay, so I think that answers the question. So let's just move on. So I've listed out a few differential diagnoses for us to rule out. So first of all would be osteoarthritis, rheumatoid arthritis, then consequently would be lupus, reactive arthritis, enteropathy, polymyalgia, and overlap syndrome. So doctor, just now you mentioned mechanical and inflammatory, right? So aside from those two classifications, are there any other classification that you could use?
That is the most common one. So when you divide it into those already, then you can further divide from there. If mechanical is more of the traumatic, sport injury, OA, and then your inflammatory, then go to the all the rheumato-immunological involvement of arthritis. For example, your rheumatoid, the enteropathic, and the lupus. And of course, there's other group is the crystallized arthritis, your gout, and the infection group of the arthritis. Your reactive arthritis is part of that, and your septic arthritis, that's very common. So you need to combine all the features to tell you which suggests to which. So in your patient, you might need a bit further. Until now, we still cannot see this is mechanical or inflammatory from the current information we have. I hope everyone know about all the differential diagnosis list by Hai Liang here. At least heard about it before lah. Okay.
Okay, so let's just move on. Okay, so presenting complaint of the patient is that the patient had a 6-month history of joint pain in the wrist and the fingers. There is a pain and tenderness in the left and right wrist, plus the first, second, and fourth proximal interphalangeal joint of the left hand, and right first metacarpal joint, and right first, second, and third proximal interphalangeal joint. So altogether, this is 1, 2, 3, 4, 5, 6, 7, 8, 9, nine small joints with a morning stiffness that lasts more than 30 minutes in these joints, and the pain is more severe in the morning, and it's relieved slightly by movement and painkillers that were recently given by Otto. So I think we can all agree that this would be inflammatory arthritis, right, doctor?
Yeah. So how you differentiate mechanical and inflammatory, the easiest ways to differentiate it is we will always ask the patient how the pain, does the pain relieved by a movement or worsen by a movement. So if a inflammatory pain, somehow it will relieve by movement. Theoretically, we'll always say as such, but sometimes when, let's say in RA patient, they are in real flare, definitely when they move their hand or the joint per se, they will have more pains. Okay, so this is the question you're going to ask. And of course, the important thing for RA, the morning stiffness is one of it. And then the multiple small joint pain. And when you clock your history, which joint, small joint or large joint, yes, but you need to go into quite specific to which joint, PIP, DIP, MTP. Each joint will give you some clues about most probably which type of disease it going to suggestive. And okay, any further history to be given?
Okay, so further history, can you see the side change?
Yep.
Okay, so other than these joints, the patient also has a 20 to 30-year history of joint pain in multiple sites, including both shoulders, ankles, and her left hip. So for these joints, the morning stiffness actually lasts about 10 minutes after waking up. The pain score was about 4 out of 10 and exacerbated by movement or pressure. This pain is normally tolerable, but the patient fell about 6 months ago due to weakness and pain. And the orthopedic surgical procedure was done to repair the fracture in the right femur. And subsequently, the patient was immobile for about 2 months following surgery and used wheelchairs and walking sticks to move around. Several ulcers on her right and ankle appeared, probably due to the trauma. So currently seeing orthopedic clinic to change the dressing. So doctor, just like to point out that these joints, these large joints, right, they don't sound inflammatory to me. Could it be another pathology, or is it the same pathology as the first one?
Yes, it could be another pathology in viewing of such a chronic history of 20 to 30 years. This lady, based on the small joint history, it sounds very inflammatory to you. I think most of you also have what diagnosis it is in your mind. So, but the confusing part is the big joint. Why she should have so many big joint problem? But with the age of 80, most probably she has some other mechanical kind of joint pain like osteoarthritis on board, especially the hip, the shoulder, ankle also possible. The most common OA will be the knee. So and the here exacerbated by movement or pressure, then it sounds very mechanical to you. And some patients, when they have RA and they are not well controlled or not even treated, for example, in this case, like 20 to 30 years ago, she already has the onsets of the symptoms. So they might develop a secondary OA on top of that. How OA develop is basically is wear and tear. So it's the same thing when you have RA, you left it untreated. They will every attack, every flare of the inflammation of the joint, it will cause some damage, erosion to your joint. Therefore, they might slowly develop a secondary OA on top of the RA. And any guess why should fail and then get a fracture? Is it because a normal, aging process or anything that you think it might trigger that? But here we do know how the fail is. Is it a very great impact of the fail, or is just a usual fail and then cause the fracture? Any history on that?
Okay, so for the history, there is I didn't really put it here, but she actually fell down in a toilet. That's it lah.
Okay. Yep. So yeah, then maybe we look further on the history, see anything that we can extract from there.
Okay, so let's just move on. For systemic review, there is no fever, no loss of weight, no loss of appetite, no rash, no alopecia, no pruritus, no dysuria or hematuria, no bloody diarrhea. So all of these should be to rule out the differential diagnosis I've stated earlier lah. Past medical history is irrelevant, insignificant. Past surgical history, right knee surgery was done in 2003 to change her kneecap according to the patient's words. So possible knee replacement surgery, not sure. Drug history wise, the patient is currently taking ibuprofen when needed, also taking traditional medication for a few months before the fall. Before the fall. So I noticed that traditional medication. So doctor, can you elaborate on if that is an important history to take?
Yeah, that is very important history. Why? In this case, is an old lady at age of 80. You might easily explain the fail and the fracture is due to the aging, due to the common progress of the osteoporosis. How about this lady is someone in the age of 40 or 50 and she had fell in the toilet and fractured her bone? So that might be a bit unusual. So the traditional history, most of the traditional medication, I would say a lot of the traditional medication contains steroids. So that you know what I'm going to tell next is your osteoporosis, the chronic injection. Okay, so in this lady, 80 years old, fell with fracture might be normal for this age. So why traditional medicine so important in this history, in this case per se? Anything that you can think of?
Avascular necrosis.
Okay, possible. Okay, something not really joint related. That for those who had done your on call in ED, and you might see has such as experience. Patient come in, BP very low, hypoglycemia, and then further dig on a history, they do take traditional medicine for some time.
So Cushing.
Yeah, so they will go into Addisonian, low cortisol and things like that, especially in the older group of patients. That's quite common. You will see that they will come in with hyponet, hypoglycemia, low BP. Yeah, so the traditional medicine is an important part. And in our society, in our population, a lot of patients, when they have this chronic joint pain, RA, those autoimmune related kind of arthritis is still not so well known among the general population. So they will think it's just a normal arthritis. They will seek all sorts of traditional medicine to help it. And if you had seen a few arthritis patients, they might tell you most of the traditional medicine, after they took it the next day, they will feel fantastic. So they give you a clue, there's some steroid in it lah. Then maybe someone will ask, rheumato also use a lot of steroid when the patient come with arthritis to us. So yeah, we do use steroid, but we will take some precaution and prevention to supplement with the calcium and vitamin D, and we will try to minimize the duration of them using it. That's why you will need your agents, the steroid sparing agents for all your arthritis.
Mm-hmm.
Yep.
Okay, so I think that settles the traditional medication aspect. So moving on, allergic history is not insignificant. Family history, one of her daughters, aged 45, was diagnosed with rheumatoid arthritis recently. Otherwise, no other significant family history. Social history, currently staying with her eldest daughter in Batu Gajah, used to work as a cook and has no history of smoking, alcohol use, or illicit substance use. So is there anything you'd like to add to the history, doctor? Or anything you'd like to point out?
Okay, what do you think in these slides? There is 3 important history that you need to get. If someone present to you with okay, she got a lot of large joint, then forget if a lot of joint pain over the hands and things like that. So basically there's 3 important history that from here that you need to get in patient present to you with arthritis. Anything?
So one thing I could see that is the rheumatoid arthritis, the history.
Yes.
Second
As you
would be,
highlight.
yeah. Second would be the smoking, because smoking is a risk factor for development of rheumatoid arthritis. Is that it?
Yeah, it kind of triggered. Let's say there's a family history of you, and then plus smoking, it might increase the risk for you to develop RA. And also in terms of treatment wise, for those smoking, they might not respond very well to the treatment, to the medication when we treat the RA. And anything else? One more?
Occupational history maybe.
Yep. Why? Poor Hai
Because
Liang. Only you answer question.
Could be that there's osteoarthritis development because of the movement.
Yeah, the nature of work the patient used to work, and then you might consider OA of the hand if that previously she worked as someone that need to use a lot of hands, like those factory operator, and then or a lot of typing and things like that. Those job that involve a lot of usage of the hands lah. Yep. Okay.
Okay, so I think that should be all. So moving on to the physical examination. General examination reveals that the patient is comfortable and alert, not in any respiratory distress. Being on air, dry dressing noted on the right knee and ankle, probably due to the fall, and there's a well-healed scar on the right knee.
Hai Liang, give me a minute.
Okay, sure. So if there are any questions, please let me know. To the audience.
Okay, we can continue.
Oh, okay. Yeah. Remember to raise your hands, yeah, guys. Okay, so moving on. Peripheral examination wise, we can see swan neck deformity noted in the right fingers and some ulnar deviation. Subcutaneous nodules are noted bilaterally on the elbows. Otherwise, no peripheral cyanosis, no jaundice, no clubbing, no palmar erythema, no palmar pallor, well-hydrated buccal mucous membranes, and some corneal ulcers actually noted. So these are the photos that is from Google, not the patient, but yeah, so you can see the subcutaneous nodules and the swan neck deformities. So anything you'd like to add here, doctor?
Okay, I hope everyone can really identify. The nodules is not that common we see lah actually. The swan neck, the ulnar deviation, and then the radial deviation of the wrist, all the common deformity of the RA, you all need to really clear about it. And especially when you, let's say you see this photo, you comment swan neck, you comment the ulnar deviation, you need to able to describe what is swan neck and what is ulnar deviation. It involve which joint that cause this deformity. So this is an important signs you really need to be able to pick up lah when you were given a case of RA in your exam or even in a DRI, because they nowadays with the advance of medication and more awareness, if you see the younger group of patients now in our clinic, actually is not that common. You see the deformity. Most of the patient with deformity is at the older generation group of patient, and then some of them may be left untreated, undiagnosed. So you will see this kind of deformity. This will be a very common question that might come out in your exam for the exam purpose. Yep.
Okay. So that's the physical examination. Okay, so range of motion for the following joints are restricted. So shoulder joint, wrist joint, finger joints, left hip and left ankle all restricted, but only the large ones are restricted due to pain. And the small joints like the wrist and the fingers, actually no pain, but there is some warmth and some tenderness noted. If nothing, we can just move on. So investigations. Okay, so let's just read the investigation. Full blood count, you see hemoglobin is 101 grams per liter. The rest of the results are normal, meaning MCV, MCH, the lymphocyte, what's that called? White blood cell count, platelet count, all normal. So this indicates normochromic, normocytic anemia. So doctor, just want to clarify, if you see this kind of level of hemoglobin, do you actually correct it or not?
10.1 is still acceptable. Sometimes you will depend on the patient's symptoms, whether they have any anemic symptom. And another main factors, despite any types of anemia, means purely anemia, it also depends on whether the patient, the underlying medical history. If they are someone with IHD, then you might want to keep the hemoglobin at least at 10. Usually 10, we won't really correct it. We will just keep as such, but definitely you need to find out the reason, the cause of the anemia.
All right. So the cause for this anemia, could we say that it's anemia of chronic disease?
You could, but before you say that, you need to really do out other things. Because anemia of chronic disease is very easy to give, but I mean you really need to rule out more acute problem of the anemia because before you can jump into conclusion that this is just purely a anemia due to the chronic disease, especially in an elderly patient like this.
And taking ibuprofen some more.
Yes, so you were thinking of maybe some chronic slowly upper GI losing. So you really need to think about that to look for that harder. And then at this age, a lot of patients, the other patient, they have some aspirin on board and things like that.
Okay, so I think that answers the question. So moving on, CRP is 5.1, ESR 61, so elevated lah. So I've read in Kumar and Clark that CRP ESR actually indicates the disease flare. So is that relevant clinically or not?
Yes, we do depends on ESR, CRP a lot other than your clinical finding. As mentioned, some chronic RA patient they might develop a secondary OA on top of RA. Sometimes they come into you with joint pain and there's some effusion, there's synovitis. So sometimes it's very difficult for you to judge this is purely just a RA flare or is a OA flare because the treatment might be a bit different. If it is a RA flare, you would like to further taper out the DMARDs. If this is just some OA or other joint pain, then you might not need to. So it's not a definitive again, it's just a guidance and a adjunct tool for you to convince you this is flare or not something. Yeah.
Okay. So moving on, renal function test normal, rheumatoid factor positive, anti-CCP positive, ANA is negative. So so last question for this investigation part, anti-CCP positive, does that give you any warning sign, or because I've read that anti-CCP is a risk factor for the disease being more severe. So is that something that you will pay attention to, or okay, just positive?
Yes, this is something, yeah, you need to. Anti-CCP, is just like a larbustranadiene and things like that to tell you that if positive is very strongly suggestive with plus the clinical features, this is RA. And with a seropositive RA, the disease tends to be more aggressive and progressive, and you really need to treat it aggressively. And a lot of them are more resistant than those anti-CCP negative patients. So yes, this is it also acts as a prognostic factor for you with a positive anti-CCP.
Okay, so next up we have a slide of okay, so we have a slide of the X-ray. So this is a rheumatoid arthritis picture lah, with the juxta-articular osteopenia.
Can you use the cursor to point out the...
Okay. I think we just go to the next one. It's a bit more clear. Okay, so like this. So soft tissue swelling would be the first early sign, and then followed by periarticular osteopenia. Joint space narrowing occurs in late. Is that true, doctor? Or am I wrong?
Yep.
Okay, so I think this is the overview for rheumatoid arthritis picture of hand arthritis.
You go back to the previous X-ray. Okay, so you can see from the radial bone, the radial stylus at the wrist. So you can see usually normal X-ray, your radial stylus will be, there is a sharp pointing up triangle shaped thing there. So that is usually the first sites that where the erosions happens lah. And of course later all your PIP, when you look at the X-ray of the patient you suspect of RA, that is the common site you need to pay attention to. And you can see from this X-ray, all the wrist joint, all the bone, the carpal bone already fused up, especially over the right side. So that's caused all the deformities that is actually happening. I hope you all can appreciate the right wrist is definitely very abnormal. The left one is still okay, but also start to the bones are start to fusing up lah.
So you mean the radial styloid, is it? This one?
Yeah, I think this one, the left one is more obvious. The whole styloid is actually flattened already over the left radius. Yeah. Okay.
Okay, so moving on. Okay, so this is the classification criteria for RA lah. So let's I just want to go through this for this case just quickly. So obviously more than 10 joints already, so 5 points. Serology actually didn't mention if it's high or low, but positive, so 2 or 3 lah. Symptom duration 6 months, so 1. Acute phase reactant abnormal, so 1. So this is definitely RA lah.
Yep. So again, this is a guidance to you lah, based on the clinical features and your X-ray also, or you have very strong evidence to tell you this is RA lah, basically. But very likely this patient on top of RA, she has a secondary OA on top of that lah.
Okay, so next. So management, we just go very quickly because we're a bit short of time. So NSAIDs, celecoxib, DMARDs, and biologic agents. So from what I've read is that you differentiate it based on symptom relieving and DMARDs. So DMARDs can be biologic or non-biologic. So non-biologic would be methotrexate and leflunomide. Biologic would be anti-TNF-alpha inhibitor. So doctor, what side effects should we look out for in treating these kind of patients?
Okay, you need to know I believe everyone know the side effects of the NSAIDs at this point lah. The most thing that we need to look for is the GI complication for the NSAID and also the renal complication. There's 2 very common side effects of NSAIDs. For the DMARDs, I think you have go through the list of DMARDs that use in RA and even all rheumatic disease. So you need to know the side effects of each of the drugs, at least the common one. Okay, so but overall, most of the DMARDs will have some effects on the full blood marrow suppression, the hematological, and then the liver side effects and the kidney. That is the common one. Of course, every DMARDs, they have their certain very specific side effects that hydroxychloroquine might affect the eyes. That's one example. Biologic agents, overall, they suppress your immune system, the risk of infection, and each group of the biologic agents also have their specific side effects. But I think at a level, you don't need to go so deep on the biologic agents. You just need to know a few groups of that and maybe one or two example, the name of it. That's all for that, because that is more to, rheumatology training
Yeah.
type already. Yeah.
All right. Okay. So just next slide, last one about rheumatoid arthritis is the DAS28 calculator. So I've seen you and doctor and other doctors using this calculator. So how is this relevant to clinical practice, doctor?
Yep. So after you diagnose, after you initiate the treatment, other than monitor your side effects of the drugs, the important thing is whether you make the patient into remission. So now, rheumato also, we aim to treat to targets, means you want to get your patient into remission as soon as fast as possible. So this calculator is basically a guideline for you to see the patient's response to treatment, how well they are treated, how well they respond. So it's to tell you the disease activity. So there's few components in it, the swollen tender joint, the ESR or CRP. That's why just now the ESR CRP is important as the diagnosis and monitoring. And then I think inside got a VAS score that is more subjective. Patients self determine how the general health conditions of them at that point of time. So all this usually we use is a calculator or apps that you will key in, and they will tell you a score, and it's either remission, low, moderate, or high disease activity. So it acts as a guidance for you to titrate your medications for the patients.
Okay, so doctor, just now you mentioned WAS. Is that the one from 0 to 100 one, or is that another one?
Yeah. The visual assessment. It's something like a pain score kind of thing. Yeah. We call it VAS lah.
Okay, so I think that's all for rheumatoid arthritis. So moving on. So for the audience, I think we will exceed by about 5 minutes. I hope you don't mind. So let's just quickly move on. So prompt 2, Miss Ang, an 18-year-old female, presented to the hospital with a 2-month history of a rash on the face, forehead, and cheeks. She also felt feverish for about the past 2 months. So I think we all can see where this is going lah, I think. Yes, doctor, or is it can be something else?
No, this is still very wide. With history of rash and face and feverish, there's so many diagnoses still can be there. Yeah. At this point, I only can tell you this might be a PUO that we don't know what is that yet. But since you labeled this session as rheumatology cases, I think they can guess where it is. But in real life, when you see such a case, it's still very, very wide at this point of time.
So when you see this kind of patient, you shouldn't go straight, okay, this is SLE for sure, is it?
No.
Yeah, definitely not, right?
Yeah.
Okay, so this is the presenting complaint. So there is a 2 to 3 months history of an erythematous rash on the face. The distribution is on the forehead, nose, and the cheek. Okay, so it worsens after the patient walked to work from her open air car park to work. It is not pruritic, meaning not itchy. There is no pain at the area of the rash, no purulent or serious discharge. It is associated with alopecia, joint pain, and swelling of the lower limb. So I think it's much more clearer now lah.
It is, but it's still maybe 50%. This kind of rash on the face, there's so many differential diagnoses, And later you will need to further, we will need to further describe what type of rash, the exact sites it happened on the face, the nature of it, and things like that. And of course, the version after walking from an air car park, you know what it tries to tell you. It's photosensitive, and okay, the no pruritic, all the description of the rash, and joint pain, swelling, lower limb, alopecia. Yes, it pointing you to some direction, but there's still a few differential diagnoses that you need to entertain if you see such a case in your ward.
Mm-hmm.
Yep.
So can you give some examples of what differential diagnosis?
Anything you can think of.
So right now, what's coming to my mind is so this distribution of rash could be a scarlet fever.
Okay.
So psoriasis. With no
Psoriasis.
pruritus. Yeah.
Okay. It is still possible. Maybe you later need to, but usually it's pruritic lah. The psoriatic. Anything else you can?
Acne maybe.
Acne maybe, but that won't cause the joint pain and the swelling of lower limb also lah. Another things that we commonly see, I mean not common, is quite rare. A condition in rheumato is adult onset steel disease. They also have rash, but it usually the rash rare is not that common to happen in the face lah. It will involve the limbs and the legs and things like that. I think your scarlet is around the rheumatic fever, the post streptococcal infection fever. These are few common thing, and yep. So that is because of the nature of the rash and the joint pain, it narrow out your diagnosis to this few. Let's say if the rash is not on the face, is over the limbs and that, then your diagnosis will be more widened. Differential will be more wide in terms of this.
Yeah, because there's the alopecia and the joint pain already, so it's quite obvious.
Yes.
But we still need to rule out steel disease and the post-streptococcal.
Yep. And I think you still also need to entertain your psoriasis lah, because at the forehead, and then it also cause alopecia in psoriasis patient, and it cause PSA with the joint pain and the swelling or lower limb. We're not sure what type of swelling. Is this a joint swelling or how is this? So yeah, we still need to entertain the differential at this point of time.
I see. Okay, so let's just move on to see what the swelling and the joint pain are. Okay, so for the joint pain, there is a 2-month history over her bilateral wrists, knees, and elbows. There was no morning stiffness, no joint swelling, no obvious deformity of the joints. Pain score was about 4 to 5, hasn't affected her activities of daily living. For the swelling of the limbs, is bilateral, 2-month history also, up to the mid-shin, not painful, and no skin discoloration such as reddening or anything else. So for the fever, she just felt feverish for 2 months, didn't really take her temperature or any medication. Systemic review, why there was no the first one wrong. No, there is joint pain. No muscle pain, no dysuria, no frothy urine, no dyspnea, no headache, no convulsions, no change in oral intake, no spontaneous bleeding. Okay, so for the swelling of the lower limb, right? Obviously, I think a lot of us may be thinking about a lupus nephritis. But could it be something that is other than that, like fluid overload or just the heart problem?
You can die or maybe you have some rheumatic fever, they can involve the heart, then it can cause all these things. It's still possible. And for these slides, the joint pain wise, what does the joint pain different from the previous joint pain, as what you notice if you ever pick it up? So what is the difference between this joint pain and the previous case joint pain?
So one thing I would say is that there's no morning stiffness.
Okay.
No joint swelling, unlike in rheumatoid arthritis, there will be some swelling, I suppose. Distribution wise also a little bit different. So there's the wrists, knees, and the elbows. So small and large joints.
Mm-hmm. Yeah.
Yeah, I think that's all I can get.
Yeah. So okay. In lupus arthritis, usually they not tends to have those swelling joints lah, and the joint involvement, large or small joint, they can have. Um, and yeah, and your swelling of the lower limbs, the second history, you think of heart failure, you think of any failure, basically liver, kidney failure can cause the swelling of the lower limb, the pillar edema. And another thing is you need to think of any cellulitis going on or not. And until now, we're still not sure it's red or not and things like that. And the feverish part, that might make you think, okay, we should assume that she has fever at home and this might be a PUO. And about the systemic review, why you asking about convulsion and then spontaneous bleeding? Actually, why such a history was mentioned?
For me, my mindset would be, if it could be lupus nephritis, maybe I want to rule out the other systemic presentations of lupus. So, like convulsions would be neurological, spontaneous
Okay.
bleeding could be thrombocytopenia or something like that, lah. That's what I think.
Okay, sure, sure. So I just want to try to point out to you, when you clerk any case, when systemic review is not really systemic review, you ask for head to toes. You can do that, but when you I mean, in any other case, when you present a case, you can ask for head to toes, but when you do your summary or you present your case, you need to exclude out those not relevant to your differential diagnosis kind of symptoms lah. That will be more impressive than a lot of students like to present from whatever they get, they will just dump into the presentation.
I see.
Yep.
Okay, so
Actually,
next time,
Hai Liang, you must end sharp at 1 hour, is it?
not really lah. We can go on, but I told them 1 hour, so I'm okay lah.
Okay, it all depends to. I mean, I just want to tell you, I'm okay if it's exceeded 1 hour lah.
Oh, okay. Okay, so maybe we just finish these two cases and maybe we can talk
Sure,
more about the other diseases if you have time, lah, doctor.
sure.
Okay, so let's just finish these two cases first. Can we move on, doctor?
Yep.
Okay, so this is the miscellaneous history. Nothing much. Past medical and surgical history is nil. Drug history: previously used a herbal paste for the alopecia, but it proved ineffective. No other conventional medications. Allergic history is not significant. Family history, nothing. Social history: the patient is single, not married, and work, works as a clerk. Stays with her parents and siblings in Jenjarom, Selangor. No history of smoking, alcohol use, or illicit drug use. So nothing much here, lah, I think.
Okay. The social history part, why single not married is important in this type of cases?
I think for me, it would be because the patient is still single and this kind of rash and alopecia could affect her social life, like her romantic life, her,
Mm-hmm.
her prospect of getting another partner.
How about in the future when you want to start treatment?
Mm,
Does it matter?
I'm not sure. Anyone from the audience?
Yeah, anyone from the audience want to speak up? Very tired, Hai Liang.
Hello.
Ah,
Hello.
hi. Hi. Yep.
Hi, doctor. Yeah, I'm Wei Chun.
Hi.
Yeah, so the one point that you mentioned just now about the social history, yes, it's very important, especially if it is a confirmed SLE patient, because if it is a fertile woman who are planning to have marriage, and then we need to maybe consider maybe she has a antiphospholipid syndrome.
Yeah.
Yeah, so we might need to have a more precautious step in taking in the family planning for the future for this patient.
Yep. Yeah. So there's a important point lah. Regarding family planning and pregnancy in the future. One is like APRS, those SSA positive serology patients that you need to take precaution and monitor closely. And also, when you want to start treatment, when you want to use certain agent, and if the patient told you, I want to have a child in maybe within this year, so you need to consider all those things. That is go more towards the counseling part of that.
Yes.
Yeah.
Yes.
So that's make this social history important in SLE patient, especially SLE usually common happen in female at the reproductive age.
Yes. Yes.
I
Yeah.
see.
Okay.
So Alia wants to say something. Alia.
No, it's okay. You already answered.
Oh, okay.
All right. Right.
Adrian. Adrian Chin.
Actually, just now, he also mentioned what I want to mention. Basically, I want to talk about the some of the drugs might be teratogenic.
Yes. Okay. Yeah. That's few important point in SLE with young women.
Okay. Okay, good discussion. So again, if you want to speak, please raise your hand. Okay, just a reminder. Okay, so let's just move on. Can we move on, doctor?
Yep. Sure.
Okay, so this is just a slide of a few of the differential diagnoses that I came up for the facial rash thing. So one would be lupus, psoriasis, scarlet fever, eczema, acne. Is there any more that you like to add or the audience like to add?
Yeah. Anyone have any idea? How would you describe I know everyone will say this is a butterfly or mala rash. How would you describe a mala rash? Actually, some acne, some psoriasis also look a bit like it. Then, what are the standout features of mala rash to tell you, oh, this is a mala rash instead of other things?
So I
Anyone?
let them talk. Yeah, anyone wants to talk?
Everyone choose to keep quiet. There is near 100 people here.
Okay, so
Lim.
Suji said Suji.
Hi. Sparing nasal fold. It's the characteristic of mala rash.
Yeah, and then usually you will spare your nasal labia for, so it basically the rash will be more prominent over all the sun exposure area lah. Of course, there is another type of SLE related rash, the described rash that can happen at the hand and the lower limbs as well. So if we're talking about mala and butterfly rash, this is how the description should be. So it's one of the characteristic for you to differentiate it from other rashes lah, all over the face.
Okay, so thank you, Suchi, for the question. So I have a question myself, doctor. So just like to know, could mala rash and described rash occur together, and how do we actually differentiate them?
Oh, it's a completely different rash lah. Mala rash is commonly happen at your face. Described rash, it can happen at your limbs and your legs, and you there's this it
Yeah,
they
doctor, didn't hear
you
you just now.
cannot hear me
Yeah, just now you
now.
went. Okay, now
Now
can.
better?
Just now the
Okay.
internet. Yeah,
Maybe, yeah.
you were
So
saying.
Mara is mainly at your face and your so-called butterfly. Describe is a completely different type of rash, and it happen at your limbs and your leg and your trunk and the body, and what do you call that? It's mainly a skin manifestation of your lupus. Okay, it can be either stand alone, just a skin lupus, or it then from there you will screen for your other organ involvement lah.
Mm-hmm.
It's a completely different type of rash compared to your mala rash.
Okay, so but can it occur together?
Sure, why not? Can.
Oh, can. Okay, I see. So anyone else have any question about the cutaneous manifestations? Okay, if not, we just move on. Okay, so this is a physical examination. For general infection, the patient is alert and comfortable, not in any respiratory distress. Patient is being on air. Vital signs are blood pressure 125 to overnight 82 millimeter mercury, pulse rate 72 beats per minute, respiratory rate 17 breaths per minute, temperature is 37.5 degrees Celsius. So it's not elevated, so not really a fever, I guess.
Low grade, I would say.
Yeah, a bit low. So peripheral examination, there is tender joint bilaterally over the wrist, knee, and elbows, but there were no restriction of motion. Oh, and there is bilateral pitting edema of the lower limb until the mid shin, as we described. I forgot to add no skin discoloration, no reddening, no pain. So cardiovascular examination, dual heart sounds noted with no murmur or added heart sounds. Skin examination would be there is a red purplish rash on the face, sparing the nasolabial folds, like we mentioned earlier. So distribution on the face would be on the forehead, cheeks, and the nose. So anything you'd like to add here, doctor?
Okay, so now it kind of tell you what is the diagnosis already. Why cardiovascular examination is important, which just now I forgot to mention, which differential diagnosis you are entertaining when you comment about the cardiovascular examination.
So I'm thinking of maybe Lippmann's sacs.
Okay, that is for SLE. Any other differential? How about if I said she had a murmur at systolic murmur at the left sternal edge?
How about the aortic regurgitations?
Aortic regurgitation. So any WAF abnormality, right? So
Yes.
what if there is, what differential diagnosis you would like to entertain? Now we haven't said conclude this is really SLE yet. So if the physical finding you found some murmur, that any things that you want to entertain as your differential diagnosis with this kind of presentation?
Rheumatic heart disease, that's what you're...
Possible. I think you still need to entertain your IE.
Infectious endocarditis.
Yeah, you need still to entertain your IE. So we will never jump into conclusion after you had complete everything. Yeah. So okay, next.
Okay. Next. Oh, okay. So that's all for the physical examination. So these are the list of investigations that we did. Full blood count, lymphopenia, thrombocytopenia noted. Renal function test is normal, but urine FEME shows protein 3+, hemoglobin 2+. Liver function shows low albumin, otherwise the liver enzymes are normal. Coagulation screening test normal. ANA positive, the ratio is 1 to 320. ENA specific, positive for anti-Smith. Anti-double-stranded DNA is positive.
Okay.
So yeah, so these are the investigations.
Any comment from the participants? You can come up with a diagnosis already, I think.
Anyone wants to try? It's pretty obvious really.
A full diagnosis. Later I'm going to point it for those I know already.
Wei Jun, you want to give diagnosis not?
Wait a second. I need to conclude first.
You think first, Wei Jun is more senior, right? Let me pick up some junior now doing UMMP one. Better say something before I pick your name. Let me see participants. Guhan, are you there?
Hi, doctor. Yes.
Hi. You know you will be picked, right? I believe. So,
So
we listened to a diagnosis, then we hear from a senior.
Okay. So this is a systemic lupus nephritis erythematous, complicated by lupus nephritis.
Only?
And and hematological manifestation as well.
Okay. Any more? The
Few
joint?
more. So many
Ah,
more.
few
Oh
more.
yeah, yeah. Everything.
The skin?
Uh,
Cannot. Okay, fine. I will get another one a bit more senior a bit than you, but Kim Ki, are you there?
Kinky. Kinky slept already. Yeah.
You don't
Hi,
answer.
Doctor.
Hi, so what is your diagnosis?
Oh, I only think of the SLE with the lupus nephritis,
Uh-huh.
hematological manifestation. Um, um, I think, yeah.
That's all also.
Uh, Alia.
Call for more help.
Okay, I think now we can ask Wei Chun to come already.
Yeah, the most senior one need to come out already.
Wei Chun come.
Oh my goodness. Let me try. I'm long time haven't touched rheumato already. So my professional diagnosis will be systemic lupus erythematosus with muscular cutaneous, skeletal, hematological, and nephrological involvement and current flare-up state.
Okay, actually this case, if from the history, it sounds like a newly diagnosed lah. New presentation, newly diagnosed, very obvious with mucocutaneous, with musculoskeletal, with hematological, and also lupus nephritis from what the test you have now. So the important thing for investigation here is the lymphopenia, thrombopenia, and liver function with low albumin also. And yeah, I believe all the serology is very clear cut to you, NA, ENA, and double-stranded DNA. And okay, so you see this kind of urine FEME, you think there's lupus nephritis. Any further thing you want to do for the investigation part of it? Any?
I will do, sorry.
Yeah.
PCR. Protein.
You want to do PCR, okay? Other than PCR, more specific?
So open.
PCR just give you an estimation of that, right?
Anything else?
Hai Liang, you want to help them? There's somebody raised
Yeah.
hand there. Yeah.
Okay, Shannon. Yeah.
Hi, doctor. Maybe a renal biopsy to see which type of lupus nephritis.
Straight away renal biopsy. How about I tell you she having day 5 of menses now with this kind of urine FEME. So you will straight away proceed with the renal biopsy based on this.
I'm not sure, doctor. Sorry.
Anyone? What test you want to do? And then yeah, you are more supported to say renal biopsy need to be done. Renal biopsy is not a procedure without complication. So yeah, so when is more definite that you say, okay, I will do a renal biopsy, and you can convincingly tell the patient that you need that.
Okay, Sarah, just now you raised your hand. You want to speak? Sarah, hello.
Oh, hello. Sorry, just now accidentally pressed it.
Oh, okay.
No, but never mind. I think maybe we can kind of rule out the cause of hematuria and proteinuria. Maybe do a urine culture and sensitivity.
Okay. Okay, fine. It turned back to be negative urine culture and sensitivity. Lim?
Okay, maybe we can repeat the test after the patient has finished the menstruation for this time.
Okay, okay. So you repeated the protein still 3 plus, maybe hemoglobin become 1 plus. So you wait her finish maybe few days later and then you repeat. When you see her, you repeat. Now the edema getting worse.
Okay, so it's indicated for the renal biopsy.
Anyone want to give me an answer, Hailiang?
Maybe one thing I would do is 24-hour urine to check for the protein to confirm
Yes, you need a 24-hour urine protein to tell you she actually is excreted out how many gram of protein per day. And urine PCR, yes, you can use that. But yeah, it just give you when you read on the result of PCR, they will tell you the estimation. Then you need to times a certain value to become a 24-hour estimation protein. So what we usually do, although this case with the serology, all the features, there is a few fulfill the SLE already, you already think of lupus nephritis, especially her albumin also very low. So yeah, so but we still usually what we will do a 24-hour urine protein, and then for you to decide you want to do the next, of course, the definitive is the renal biopsy.
Okay, so I think that's all the questions for. Okay, Adrian, you want to ask questions?
Doctor, do you, other than the ANA and the anti-double stranded DNA, do you also do the anti-phospholipid syndrome, the anti-SSA, SSB, all that?
Good question. So there's a ENA specific there, right? So now I'm going to ask you all back, what is inside the ENA specific in UMMC blood test result?
Adrian, you want to start
Can I
first?
try?
Yeah, go ahead.
So if I'm not mistaken, the ENA extractable nuclear antigen in UMC here, it includes the anti-Smith and anti-RNP, anti-La, anti-Rho, anti-SEC70, and anti-Jo.
Yeah, so your anti-La and low is part of your SSA and SSB lah.
Yeah.
So will you do, this is UMMC, but if you go to other hospital, they didn't really have so easily available this kind of test.
Yeah.
By right, all the female prepared to get pregnant, we will do at least we'll do the SSA and the SSB, because of just now we mentioned the SSA can cause some problem to the pregnancy. And regarding the lupus anticoagulant wise, usually we wouldn't routinely screen that except that you have suspicions from your case. Maybe they got some thrombotic event, they have recurrent miscarriage, or another hints to you is that those patients with prolonged APTT, and then your mixing test is not correctable, then you need to consider about that in that group of patients for the lupus anticoagulant and the cardiopin. Okay. Now, what is the implication of positive SSA to the pregnancy? What you want to tell the patient? Let's say this patient SSA is positive and she get pregnant now. Anyone?
Okay,
Lim
Jia Xiang.
Good morning, doctor.
Hi.
So, maybe we need to consider about the heart block in the fetus.
Yes, okay, so that's an important thing. So someone with SSF positive, when they get pregnant, it can cause a heart block in the fetus. So you need very close work with your ONG colleague. They need to monitor the baby heart block from the very early pregnancy to identify any of that. Yeah, so this is a few things regarding the counseling part of the SLE lah. Okay, any more questions?
Okay, Natalie.
Hi, doctor. I'm Natalie.
Hi.
So I just want to ask, under what circumstances would we suggest the patient to undergo termination of pregnancy?
Okay, that usually will be a multidisciplinary decision when patient is in very bad flare, okay, that you need to use certain drugs to treat her, but the drugs might harm to the baby. Okay, for example, your patient coming with very serious flare with renal hemato multi-organ involvement, that or very bad case that you want to think or use cyclo or those very toxic agent. So again, depends on at which weeks of the pregnancy. So we need to discuss with PIDS, with ONG, to discuss with the patients as well. You need to clearly explain to them all the effects of the treatment and things like that. It might cause what harm to the baby. Okay, that is another a very big topic lah. So the rough idea is that you need to discuss any harm to the baby, what will happen if we didn't terminate, or we keep the pregnancy, we proceed with all the treatment, what might happen to the baby. If the couple thinks okay, they want to take the risk, they want to keep the baby, we need to follow patient wish lah. Okay, but we can give our advice through a discussion, but of course we need the help from the pediatrics and the ONG side as well. Then we will ask for termination. But that's why that's very important regarding the counseling in all the reproductive age ladies with SLE to prevent such a situation to happen. We usually will tell the patient when your disease really stable already, then we allow them to go for pregnancy. We will advise them not to, but again, is beyond us, is their decision.
Okay, thank you, doctor.
Yeah.
Okay, so is that all? Maybe we just move on very quickly
Sure.
to the next criteria. So this is the criteria for the diagnosis. This if I'm not mistaken, this is the ACR EULR 2011 criteria. So all of these.
I think this is the latest criteria.
Oh, this is latest, the 2019 one, or?
Before you go to the next slide first.
Yes, one.
This is your SLIC criteria. This is the old one. So now they come out with a latest criteria, the newest. This is the one I think is always had appeared. The SLIC criteria is the one that in your Oxford, I think. Yeah. So this is the old one. So the slides 28, that one is the latest criteria that you follow. Okay, so you go back, it is a bit different lah. You need an entry point of an ANA of at least more than 180 in that. So you can see actually the criteria is more loose actually. Okay. And you need to see the additive criteria. So they will say you need to rule out other possible things first before you consider this is such a SLE. So again, it's telling you that this is just a guidance to you. It doesn't use to diagnose a SLE, but it's just a tool or a guidance to you to see how likely is it. The criteria in it is around the same if you compare to the SLIC criteria, just that now they use the scoring system. And the renal part is still the same. Once you confirm your what is that, lupus nephritis, then you will usually label the patient as a SLE. You can see once you confirm class 3 to 4 of lupus nephritis, you straight get a 10 marks of it. So you will have the diagnosis of that. Okay. I think this criteria is just a guidance. You just need to know what's inside. I think, yeah, nobody going to ask you. I doubt you need to remember all the scoring, which carried how many score. I don't think so. Okay, just need to know the criteria.
Okay, so let's move on to management. Okay, so for management, this is a bit more tricky because from what I've read, actually a lot of different books will have different recommendations, I think. So for example, this I got from the past test MRCP note. It's just one text like this, and then in Kumar and Clark is another block of words which is a bit different, but they don't really specify what drugs to use, when to use what. So, doctor, maybe you can clarify on maybe this slide.
Okay. Okay, so SLE actually very simple and complicated, right? So the simple one that mentioned here is the very basic principle of treatment of SLE. Sunscreens, of course. Why? Even they got no Mara rash, they got no rash, skin involvement, sunscreen is still an important measure in all SLE patients because sunlight itself has it can trigger and lead to the flare of the disease. Okay, NSAIDs for arthritis, that is mainly just for symptomatic and suppress the inflammation process of the arthritis. Hydroxychloroquine is the backbone of treatment of SLE. You need to be on hydroxychloroquine despite your disease is active or quiet or whatsoever. Once we diagnose with patient with SLE, we will prescribe the patient with hydroxychloroquine for lifelong. As you can see here, it can reduce the risk of the flares even you are asymptomatic. So your corticosteroid, I believe those have classes with me before heard that many times. There are few types of corticosteroids, your IV, your oral, even your IM injection. Okay, IV, if you happen to in rheumato ward before, we will use IV methylprednisolone, and we will always mention pulse the patient. That's what it means. We give high dose methylprednisolone to the patient with acute flare of the major organ flare. So we will give a course of metapred for around 3 days for that acute treatment. Okay, if the patient so happen together with infections that you are worried with the steroid will make the infection worse. So another things that we can use is IVIG. Okay, then after you pulse, the patient get better, you want to discharge, they need to be maintained with oral prednisolones. So how we give is either 0.5 or 1 mg per kilogram on discharge. And then subsequently, we will slowly taper down the patient during the DCA. Every 2 weeks, we will try to taper down the prednisolone by 5 mg, 5 mg per every 2 weeks. And then if it's a major organ involvement kind of flare, like your kidney, your brain, your hematological, then we will tend to keep the patient with very low dose prednisolone for at least a year. Okay, then only you slowly see whether they can off from the prednisolone. So regarding I will talk about immunosuppressive later, plasma exchange and the so-called rituximab, belimumab, all are in the very advanced disease lah. And a clear-cut indication for plasma exchange is when patient develop pulmonary hemorrhage, then you definitely need them to have a plasma exchange. Anyone have any idea in one more situation that you need plasma exchange? Do you need to talk about methylprednisolone and whatsoever? You need a plasma exchange in what condition? Related to SLE, of course. Any idea?
Okay, I'm stumped. Anyone want to give the answer?
Everyone quiet. All fall asleep already. Okay.
I can try.
Okay.
So what I'm thinking is maybe lupus nephritis.
Not really.
What else?
Sorry, what about very high titer of ANA?
This is you dig a big hole. Okay, right. Who is this? This just now is Lim. Adrian.
Adrian.
Okay, I ask you back. Okay, when will you deplete ANA?
I suspect a flare.
Is it?
I don't know. Just trying. I don't know.
No. And okay. I have a lot of patients in clinic, walk in and out of clinic very well. We see every 6 months with A&A title of 1 in 2,000, 1 in 1,000 plus. So what do you think?
So it does not affect the
Yeah.
severity.
So yeah, and usually we won't repeat the ANA to determine flare. We will use double-stranded DNA instead to tell you whether there is an acute flare or not. Usually your ANA positive when the diagnosis time positive mean positive lah. We won't repeat it anymore further. Yeah. Even there's new onset of symptom, new onset of other system involvement that also ANA, we will not test it on ANA again. Double-stranded, yes, we use to tell us that whether this is an acute flare, especially in those very confused kind of cases, whether this is infection or this is flare, that kind of situation. Yeah.
Okay, so Lam, you want to ask a question? Or do you want to answer? Ian.
Oh, sorry.
Yeah.
Could it be
Sorry?
Could it be IHA?
Yes, which type of IHA? Warm. Actually, it's not IHA. MAHA? Heard about MAHA?
Oh, yes.
Yes, okay. Or a situation that they will go into TTP, then yeah, you need a plasma exchange. Another is a more complicated cases is like catastrophic APLS. Yeah, I think that will be a bit too extreme for you lah. A catastrophic APLS also you need a plasma exchange. There's few common situation in rheumatology that we will ask for a plasma exchange. Yep. I think somebody want to ask something.
Jin, you want to ask something?
No.
Oh no. Raise lower your hand.
No, I want to answer the question.
Oh, okay. So what you want to answer?
No. My answer was TTP lah just now.
Okay, good. I think TTP common or not common, not really. Yeah, it depends. Maybe you want to tell me what are the features make you think of TTP?
Anemia, thrombocytopenia, fever, neurological symptom, and renal failure.
Okay, and they tend to have high bilirubin from a blood test, and they were fitting for no reason suddenly. That is another thing. Then you would think this is cerebral lupus. This is any other thing. So how you diagnose TTP?
Using that pentat just now.
Huh? What is that?
Using the TTP pentat.
Okay, but your patient have all those. A lot of things can cause all those situations, right? Anemia, renal failure, neurological finding.
SLE positive.
Not only SLE patient can have TTP. What test? Sure. Okay, to be exact, what test you want to do?
Not sure.
Okay, PBF. What will you see in your PBF?
Less red blood cell.
There's anemia. Okay. Anyone want to help her?
Sure.
Later, nobody want to raise hand already.
Okay. Wong Win Yi, you want to answer?
Yeah, cystocyte in the PBF.
The MAHA picture lah, technically. Okay. Yeah.
Okay, I think answered the question already lah.
Okay. Okay, so there's plasma exchange. So now immunosuppressive, the NEMATs, that is another huge topic, but briefly, the principle of it, SLE treatment is based on which organ involvement for you to decide of which immunosuppression or which DMAT to use. For example, joint, you will use MTX, and then the hematological involvement, we will use azathioprine, and lupus nephritis, cerebral nephritis, we will give cyclophosphamide, and then the lupus nephritis, you also can use CellCept, and certain lung condition, ILD, interstitial lung disease that related to SLE or RA, we can use cyclophosphamide, and what else? The common one. I think that is the main thing about it. Sounds easy, right?
I don't know. I would find that the SLE treatment are a bit complicated because they are all different based on their different organs.
Yes, when you come to real life, real patients, of course, is a bit more complicated. But I think what I tell you is mean for at this stage, at your this stage. I mean, if you can know that SLE is based on which organ, because rheumato itself is a sub lah. If you ask a lot MO or certain, they also they also not that covered with all those things. So you basically just need to catch the principle that the basic treatment we mentioned just now, the sunscreen, steroid, whatsoever, and then the SLE, we treat it based on which organ is the manifestation, because every patient will have different organ. Some have more than one organ. So how should you choose your agents and things like that? You just need to know which system to use, which DMARDs, maybe one example will do. And then of course, clearly you need to know the DMARDs and the side effects of it. And I always tell the groups that you need to know a little bit how the medication is given, maybe IV, oral, how many times a day. For example, as the special one is the cyclo. Anyone know what is cyclophosphamide, and how we give that, and how you should counsel the patient before you start on that?
Yeah, Suchi.
Hi, just give it a try. So
Okay,
we
sure.
have to give cyclophosphamide, you have to tell the patient that's the maximum dose we can give. I mean, cumulative maximum, because it will cause irreversible complication, but I can't remember what's that. Then we need to hydrate the patient adequately before we start to give the drug, because it will cause hemorrhagic cystitis, I think.
Okay, yeah, that's one of the side effects.
Yeah. Oh, yeah, the severe complication, it's something to do with ovaries, isn't it? Can't remember.
Yeah, it will cause a bit of infertility.
Yeah,
Anything else?
infertility. This is what I can think of now.
Okay, so how is given? How cyclo is given? How, I mean, IV, oral, how frequent?
Anyone wants to try? Nobody wants to try.
My current UMMP 3.1, I thought I just talked about it not long ago.
Oh. Oh.
No wise. Okay. So
it's through oral. Yeah.
is it for lupus nephritis? There is two types of cyclo, oral and IV. I'm agreed. So if for lupus nephritis, usually what are the first line that we commonly use?
Okay, still low dose IV.
Okay,
It's not oral.
we will use IV cyclo, and based on the patient's body weight, and you need to calculate on that. So why I'm asking that, not that because you need to know in detail of these drugs and things like that. I just want you to know that it's given IV, and then the patient will tell you they need to come to hospital or daycare to get the infusions. There's total of 6 doses and things like that. Why is it important? If you clock a patient's is usually the SLE cases given to you, it's very rarely for you to get this kind of freshly presentations kind of things first diagnosed. It always they are known SLE case with multiple complication and admission with very long grandmother story. That kind of cases will come to you in your long case. I'm now talking about more exam purpose point of view. So that is the case that will give to you. So a patient tell you I receiving these drugs for six cycle of this drug, then you roughly know what is that. If they can't tell you that they got lupus nephritis, so like MTX is a 1 a week dosing drugs. So when they tell you, oh, you know, most probably this patient is on MTX. So this is how you need to know a little bit on the medication per se. And also for your daily clocking in the ward with the patient, some patient very educated, they can tell you I use Salset, I use Cyclo. Then you know sometimes you do know about that, you feel a bit embarrassed sometimes when the patient tell you I use about that, then you look blur to the patient. So get a very brief idea. And very important thing about Cyclo is again related with the pregnancy. You really need to tell the patient they can't get pregnant during receiving the cyclo treatment, and even up to 3 to 6 months after the cyclo also they can't get pregnant. That's a very important message you need to tell the patient. Include in your discussion, you know. Yeah. So that's about the cyclo. And any question from anyone?
Sorry, doctor.
Yes. Hi.
Just want to ask if because of the side effect of the cyclophosphamide, can we actually use mycophenolate instead of
Yep.
cyclo for
Yep.
lupus nephritis patient?
Yep. You can use that, yeah, of course, but I think Cellsep you hardly see because it's very expensive lah. It's more of the cost wise. Actually, if you can in the reproductive age patients, they want to get pregnant, then Cellsep is one of the options.
Okay.
Okay, thank you, doctor.
Okay. So I think that should be all. Any more other questions? If not, I have one or two last questions, like if you don't mind.
Sure.
Okay. So just now you mentioned IVIG is given for patients who are in risk of infections.
Yes.
Yeah. So I think a lot of us will have questions. Why IVIG give for immunosuppressive? What do you call that? You're trying to suppress the immune system, but you give IVIG, which is actually immunoglobulin. So how does it actually help to, suppress the immune system?
Okay. As you see, what you understand about IVIG?
So for me, IVIG is a human human. Is it human or? I think it's an animal. I'm not sure which one, but it's a recombinant immunoglobulin, and then given in cycles.
In cycles, usually it's given for 5 days lah. Okay, it's a kind of how to say that it modulate your immune system. Okay, so if we give immunosuppression in a infected patient with infection, you will make the infection worse. So we need to how to say you need to replace and emolulate your immune system with the IVIG. For example, you see a lot of diseases even in neuro, your MG, your transverse myelitis, we also use a lot IVIG to modulate your immune system. Your autoimmune diseases is basically your body immune system produce a lot of auto antibodies that attack your own body. So you want to change that system. So usually IVIG after you give, they can last about almost 3 to 6 months for the doses. So that's how we use IVIG. Of course, its effects whether as good as immunosuppression that we not sure, but only indication we really use the IVIG is that when there is a severe infection. If it's a mild infection, let's say some pneumonia that covered with antibiotic together with your methylprednisolone should be good enough and should be no concern with that to continue with that.
Okay. Okay, that answered my question. So last question about the first case, the first case. So I noticed that the patient have some actually like, I don't know if I would put polymyalgia rheumatica into my differential diagnosis.
Okay.
Thing to do.
Polymyalgia rheumatica actually is also a diagnosis of exclusion. Okay, so and it's commonly happen in the elderly above age of 60 and above, and typically they will involve more of the big joint, large joint than the small joint, and the ESR usually will be very very high lah. I mean, just now your patient is around 60 is borderline, so you can consider that as one of the differential diagnosis from the start itself. And usually polymyalgia rheumatica of the patient then in the elderly, also that you might want to screen them for the giant cell arthritis, those kind of things, some jaw pain, headache and things like that. And very typically they happen over the shoulder. They will tell you they can't raise the shoulder and things like that. For your case just now at the 80 years old, let's say your patient eventually there is no deformity found as per your case, then that might be might be my diagnosis for that. And without the x-ray changes, without the positive antibody, yeah, that I will consider that as one of the diagnoses for an old lady with this kind of presentation.
Okay, so that's the question for me. Anyone from the floor? Sorry. Yeah, someone.
Sorry, doctor.
Yeah.
Yeah. Means just if patient is happen to have a severe infection, so we won't give steroid to the patient, so we just give IVIG to the patient, is it?
Yes, we will give the IVIG. Of course, the oral steroid, even IV hydrocort is okay. Usually, if they had severe infection, we won't use the methylprednisolone.
Okay. Okay.
Okay, anyone else? If not, I think we can call it a day. So, okay, so thank you, Dr. T, for sharing with us, exceeding a time limit a bit. Actually, 43 minutes. Okay.
No problem.
Thank you, doctor. So I think you can go have your lunch now already. Thank you.
Okay, thanks. Okay.
Okay, thank you,
How
doctor.
you all help you all benefit from that?
Yeah, I think it's very beneficial.
Thank you, doctor.
Okay, sure.
Thank you so much, doctor.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Long time haven't see you.
Thank you, doctor.
Yeah.
Okay, guys, can do the feedback form. Thanks. Okay lah. Thank you,
Bye.
doctor.
Okay. Bye.
Have a nice
bye-bye,
day.
doctor.